So I'm going to be talking about hacks for a better transition from pediatric to adult care. I hope participants will be asking questions. This was designed for patients and caregivers, but I see there are a few healthcare providers as well, so I'm happy to answer any questions that come from any side. So the problem with transition is that patients are going from a place where they have been treated for several years, most times, and they're going to a new place with new faces. So a new system, new healthcare team, and the teenager with epilepsy is expected to behave as a grown-up who is able to make their own health-related decisions and take responsibilities. The other part of the problem is that the brain is not mature at this time. So we know that the brain will be completely matured by 25 or even later. So by the age of 18, when the transition is made in most places, the brain is not mature. You can see here the green areas are the areas where the brain is still green, not matured yet, and the blue is where you see maturation. So starts with the occipital lobe, so the baby can start seeing, and then the regions in the somatosensory regions, so the baby will start having control of his body, and it goes on and on and on. And by 18, the frontal lobes, these are the last areas, some of the last areas to mature. And this is exactly where you have judgment and planning. And that's probably why we see teenagers acting like teenagers, because that part of the brain is not mature yet. What happens with the epilepsy? So when you have a child with seizures, if there are no other neurological problems associated, 75% of these children may stop having seizures when they become adults. However, if the seizures are associated with other neurological problems like intellectual disability, autism, global developmental delay, which is the case for most epilepsies that are caused by a single gene disorder, then only 25% of those cases will remit, so they will stop having seizures when they become older. So if we talk about transition, actually we have to talk about two different groups of patients. One is the patients that have epilepsy without other neurological problems. They may have some learning disabilities, but don't really have other serious problems. Some common examples are juvenile myoclonic epilepsy, temporal lobe epilepsy, cortical dysplasias, or patients that had surgery because of a tumor, like a dysembryoplastic neuroepithelial tumor or a meningioma or something like that. These patients may or may not be taking medication when they graduate to the adult system. And it's important to remember that even though they don't have other, what we call neurological problems, they often have psychiatric problems like depression and anxiety. The question that we hear in case of, for these patients is mainly, I'm going to college, or the parents will say, my son or my daughter is going to college, what should I know? And we'll talk a little bit about that. Sorry. Why this is not going. We have seen that long-term studies, when you look at children that had seizures in childhood and they grow older, what happens to them, and compared with other diseases that affect children around the same age. So one of the examples is juvenile rheumatoid arthritis. And it's disheartening to see what happens to patients that have epilepsy as children compared to others with other diseases. So the rate of unplanned pregnancy outside a stable relationship is much higher for patients that have epilepsy. Social isolation is much higher. Behavioral and psychiatric problems, like I said, depression and anxiety, sometimes rebellious behavior, also much higher in epilepsy. Lower education, even if you look at the parents' level of education, the children that had epilepsy usually have a lower level of education and increased financial dependency. Now we have that other group of patients that I mentioned, patients that have other neurological problems. And in this case, there are many genetic epilepsies or monogenic epilepsies, those caused by a single gene. This is the picture of a patient of mine with DRAVET syndrome, and this is an authorized picture, by the way. So she, like many other patients with monogenic epilepsy, she has intellectual disability, motor problems, and this happens to patients that have cerebral palsy and sometimes progressive myoclonus epilepsy. So these are other forms of epilepsy where seizure is one of the manifestations, but it is not everything. So often these patients are on too many medications, and some of these medications might not be very used in the adult system. So that might pose a problem. I'll talk a bit more about that later. The seizures might not be controlled despite the fact that they are on several medications. Sometimes they had surgeries, the surgeries failed. They have a VNS that didn't help very much. They are on ketogenic diet, and that's a dilemma as well. I'll talk a bit more about that. And like I said, they have several other comorbidities, as we call, so moderate to severe intellectual disability, autism, behavioral problems, gait problems, other motor problems, abnormal movements that are not the seizures. So they have the seizures plus other movements, sleep disorder, constipation. So it's a host of other problems. In those cases, what we see are parents asking, what's going to happen to my son or my daughter? No one will care for them as well as the pediatric team did. So that's really a challenge for these patients, perhaps even more difficult than for the others without neurological comorbidities. The families often feel abandoned. They feel like, okay, who's going to catch me on the other end? I know I was well cared here by the pediatric team. Who's going to take care of me on the other side? And I say that, I should mention, I am an adult neurologist. I see the patients that are coming to us after they left the pediatric system. So I know how difficult it is for these patients coming to us. We also have to be concerned about the declining health. Poor medication compliance can lead to more seizures, more admissions to emergency room or even ICU. There are a few transition guidelines. We designed one specific for patients with seizures, with epilepsies, and I'll talk a little bit about that, and then I'll give you a few resources. So again, for these guidelines, we divided the patients into two groups, those that have epilepsy and normal intelligence or just a mild learning disability, and those that have epilepsy and intellectual disability. I'm sorry. There are 7 steps, and here you can see the ages of these patients, and you'll see that the transition should start early. The first step is to introduce the concept of transition. And one of the models is the shared management model, where when the patient is young, the provider, the healthcare provider and the family or the caregiver are the main ones taking care of this child. But as the child gets older with time, he or she should start taking up some responsibilities. So the patient is initially someone just receiving care, eventually someone participating in his or her care, and then eventually someone managing the care. How is that done? So the patient we should encourage the patient to talk at the medical appointments, talk to the nurse, talk to the physician, explain their feelings, their side effects, if any. As the patient gets older, perhaps managing his or her medication. So we'll talk a bit more about that as well. The second step is to explore financial, community, and social support. And that's something that should be done starting at the age of 12 years, because some of the things can take a long time. So things that are important to think about: education. So if this is a patient that doesn't have an intellectual disability, might be planning going to college, will this person need some kind of special accommodation, perhaps a shared room? Would it be good if the healthcare team could provide some letter to the accepting university, for instance? Or if this is a patient that has moderate to severe intellectual disability, is going to need special education, what happens after the age of 18 or perhaps 21? So some places you're going to have special education up to the age of 21 years, but nothing after that. So it's important to start to explore what's going to happen. The other issue is housing. Like I mentioned, if the person is going to university, what kind of setting is this person going to be living in? The university is a challenging environment for any teenager. If it is a teenager with epilepsy, it can be a bit more. So perhaps a place that is quiet, the person has a place to rest, quiet, but maybe with some living with some other person in case there is an emergency. So there's a lot of things that should be thought about and talked about with your healthcare team. If it is a patient with moderate to severe intellectual disability, is this person going to be moving into a group home or some kind of institution that will house this person going further? So all that needs to be talked about before the patient leaves the pediatric system. Insurance cover, very important. It can change at the age of 18 or 19 or 21, depending on the plan. So it's important to know what's going to happen after that. Guardianship, that's something that when you have a child, you go to your child, even if he or she is 17 years old, 17 and 11 months, you go to a pediatric hospital. No one's going to ask you who has the power of attorney. They will ask you for they will ask the parents, and that's it. Now, when this person is 18 and comes to an adult emergency room, then things are different. So they may, if the patient is unconscious, they may just ask who can help, but eventually they might ask who has the power of attorney, who is the responsible for this person, who is the person making the decisions. So it's very important to set this up before leaving the pediatric system. Respite care for parents of patients with complex epilepsies. So again, something that has to be set up before they leave the pediatric system. Moving on, the next step is to determine transition readiness. That means, how ready am I to go to an adult healthcare system? We have, in this publication in 2017, we designed two questionnaires, one for the teenager, the patient, and one for the parent or caregiver. Don't worry about taking a picture of this. The Neurology Child Association has very similar questionnaire. It's not specific for patients with epilepsy, but it's very similar. It's for patients with neurological diseases. So Child Neurology Foundation, they have this, and I'll link that at the end as well. So the things that are important for the patient to be able to answer is, can I describe my health condition and explain my healthcare needs to others? I know what triggers my seizures and how to minimize the triggers. I know what to do in the event of a medical emergency. for instance, when to call 911 or have someone call 911. I know when to call the doctor about unusual changes in my health, for instance, side effects, and how to call the pharmacy and order medication earlier, and interaction with medication and birth control pills. So there's a host of different things that are important in the management of this person's own health related to epilepsy that he or she would address by answering this questionnaire. And things that are not answered, yes, I always do that, are the things where the healthcare team should come and help this person. So for instance, let me get one question here. I spend time alone with my healthcare provider at each appointment. If he's not doing that, and this patient is at the age where this should be offered, 15, 16, 17 years old, okay, so the healthcare team will provide some private time with the patient without the parents involved. Something else like, I don't know how to order my medication. So again, someone from the healthcare team should address this question. The next one is about risk factors for an unsuccessful transition, especially in patients that have normal intelligence. So these are different from the patients that have other comorbidities. I'll talk about that in a sec. So one of the things is inconsistent medication compliance. So the person forgets to take his medications or her medications. And that happens in a huge number of young adults. And if you ask them why, they will say sometimes because they forgot their medication, sometimes because they didn't have the medication in hand, or sometimes because they actually had the medication, didn't forget, but were just thinking maybe they didn't have seizures for a while, maybe they don't need the medication anymore. And that's when they have a seizure. So we've seen that several times here. There is literature on that as well. So unfortunately, teenagers might have a tendency to not be very compliant with the medication, and that poses them at a very high risk of seizures again. The other issue is the risk of an unwanted pregnancy. Again, it is important that the teenage knows about interactions between anti-seizure medications and birth control pills or patches or whatever methods of birth control they are using. So it's important to know about this. If your doctor haven't talked to you yet about this, go ahead and ask, or ask the nurse. If you're ashamed to ask the doctor for any reason, shouldn't be ashamed. But anyways, ask someone in your healthcare team. Driving is another important issue. And again, being seizure-free is essential for driving. So it is important that the patient knows that a good seizure control is what's going to determine if they're going to be driving or not. And finally, we have to address depression, anxiety, and other psychotic disorders. So very rarely patients can have, like I said, psychotic problems, but depression and anxiety are pretty common. And many times we as healthcare practitioners don't ask questions about that. So if you feel that you might have some of the symptoms, go ahead and tell your doctor, your nurse, or someone from your healthcare team, because it's very important to look for help when there are these kind of symptoms. There are a few tools to look for this. Some of them are very broad in the sense that they also will look at your home environment, your school, the use of social media and things like that. So some of them, the patient or you can auto screen, you can do the screen yourself. Some of them you need someone from your healthcare team to guide you through the screening process. Patients that have epilepsy plus intellectual disability, moderate to severe intellectual disability, they are in a different group of patients in the sense that they have different risk factors. So one of them is the fact that they might not engage so well for EEG, for MRI, for blood work. This might not be a problem in the pediatric hospital where the staff is used to working with children and young adults that behave like children, but this might be a problem in the adult healthcare system. And so it's important if you're a caregiver for someone who has intellectual disability on top of the epilepsy, it's important to ask your child neurologist, where are you going after you leave the pediatric system? Are there in this new place people that will be able to manage this kind of tests? Should I repeat any test for my child? Should we do another MRI because he or she needs general anesthesia and it's harder to get that in the adult system? Should we do one here when he's 17 plus? So all that should be discussed with the healthcare team. The other challenge is that some of the epilepsies associated with moderate to severe intellectual disability, they are part of syndromes that are not very familiar to the adult epileptologist or adult neurologist. And sometimes they are not very familiar with the particular medications. So some of the examples are fenfluramine, stripentol, everolimus. So these are the medications used in rare epilepsies. So not every adult neurologist will be familiar with those. And we confirmed this on a research several years ago that patients with what we call epileptic encephalopathy or epilepsy in association with genetic disorders pose more of a challenge to the adult neurologist than to the pediatric neurologist. So the pediatric neurologist is way more comfortable and familiar with those syndromes than the adult neurologist or even the adult epileptologist. Next step is to reevaluate the epilepsy diagnosis. So if you have a patient that has paroxysmal events, and it's a patient that has normal intelligence, usually you think is seizures, but sometimes you have to think, okay, are these a little different from the old seizures he used to have? Could this be what we call PNES or psychogenic non-epileptic seizures, which if they are PNES, and they can coexist. So a patient might have epileptic seizures and non-epileptic seizures. The non-epileptic seizures usually are associated with significant psychological problems like stress, anxiety, depression, so things that need treatment anyways. So we need to diagnose to be able to treat. In patients that have intellectual disability and have paroxysmal events, so they could still be the seizures, but sometimes they are different things. They can be what we call autonomic dysfunction, for instance, just skin flushing, or the pupils get very large, and that might have represented a seizure when this patient was a baby, but now they might not necessarily mean that. So that's something important. Another thing that is tricky is mannerisms. So patients that have autism and have these repeated movements that are just their mannerism, they are not seizures. So it's important to understand what is what, so we don't treat mannerism with anti-seizure medications because it's not going to help. And abnormal behavior, and even PNES, we know patients with intellectual disability might also have PNES. In the reevaluating the diagnosis, sometimes we need to repeat the EEG or video EEG. Sometimes we need to repeat the MRI, and sometimes we need to repeat genetic testing. So a patient is 17 years old and had genetic testing 17 years ago when the seizure started, or 15 years ago when the seizures started. We might not be able to, we might not have found the results just because the technology wasn't there at the time. I'm not saying that the patient didn't receive a good workup. It's usually the other way. Usually the patients with severe epilepsy, they got the $1 million workup treatment, but that was several years ago, and we didn't have the technology that we have today. Even today, when we have a patient with a genetic test that is negative, we know in 1 year we are going to reevaluate to see if some of those things that really didn't pan out this year, 2021, maybe next year we'll know that they are associated with seizures, and that might change the treatment. So it's very important. The other thing why it's important is some people will say, why make a genetic diagnosis if the patient is already 17, 18, 19? You're not going to change the outcome. Well, with certain genetic disorders, yes, you can change the treatment, and you should change the treatment. But also there's the issue of siblings that are of childbearing age, and these siblings might be concerned about their ability of bearing healthy children. So if you know what happened to the patient, what is the genetic change in the patient, you might be able to test the siblings and tell them if they are carriers or not. In terms of obstacles for drug-resistant epilepsy, neuromodulation might be an obstacle. So patients that have VNS or DBS or RNS, any of these neuromodulation devices, they have to be sent to specific adult neurologists who can manage that. So they might have to travel a bit farther away, depending on where they live, because you might not have a specialist that will see RNS in your area, in the adult system, while you could have in the pediatric system. The other issue is insurance as well. So all that have to be thought about and planned before. Of course, the next big challenge is patients that are on specific diet therapies, like the ketogenic diet or the modified Atkins diet. We are lucky in a way that in North America, there are so many pediatric centers that have a specific ketogenic diet or an epilepsy diet clinic, but there's only a handful of those in the adult system. So if a patient is on a diet that is working at the age of 17, what is going to happen when he turns 18 and goes to the adult system? So this is the kind of thing that if you are a caregiver for a patient on the keto diet, you have to ask your doctor and make plans for what's going to happen. Should you wean off the diet for your son, or should you be in contact with someone, perhaps now with so many Zoom, web call meetings, maybe someone can see you from a distant site, so that your child can continue on the diet therapy. But I mean, it's a significant problem and can be a significant barrier for a successful transition. So you have to think about that early and discuss that with your doctor early. And finally, we want the pediatric health team to prepare what we call a discharge package. So that would include the transition readiness questionnaires, the results of the psychosocial screening to check for anxiety, depression, stress, the epilepsy history form. So it's very important that everybody understands that transitioning is not just handing in all the piles of charts from the age of 2 to 18 years. So that really doesn't help anyone. It doesn't help the patient, doesn't help the doctor in the adult system, it doesn't help anyone. Having said that, I recognize the time limitations from the physicians that in the pediatric side. So that's why there are these guidelines and systems where you can do one thing at a time, and with time over this 6 years before the patient turns 18, you have time to do everything that is needed. It's very important that the patient leaves the pediatric system with the epilepsy history form. Seizure emergency protocol, extremely important. Goals of care, referrals, and community social and financial support. So about referrals, I just want to mention, sometimes the patient is seeing several different specialists. So the child neurologist, the child psychiatrist, the pediatric ophthalmologist, and when they move to the adult system, sometimes if it is the child neurologist making the referral, this person can make the referral to an adult neurologist, but you won't have the other specialties in the adult system. So it's very important that you talk to each one of your healthcare providers in the different areas and ask them who are they going to send you to in the adult system. This is an example of the epilepsy history form. It's a more summarized way of getting the medical information. So I will go through this quickly. I want to show you this page from the Child Neurology Foundation, which is a very helpful tool. They divide it in 8 steps, but it's really, the 8 is the transfer, completing the transfer. But as you see, it's very similar to the things we talked about. And this is very patient friendly. You can go to childneurologyfoundation.org/transition. So see here on the bottom of the slide, on the left bottom of the slide, the website, you can go there, and there are several tools that you can use, you can download, you can ask your healthcare team to fill out those forms. The self-care assessment is equivalent to what I call the Readiness questionnaire. So things here are very similar, just have a slightly different wording, but the transfer letter sample, all that is very similar. So if you are in a place where there's no a transition program, it would be wise if you could go to the website and explore and see what is available there, and then engage your healthcare provider so he or she can start helping you with this transition process. So I mentioned the seizure emergency protocol. The worst thing that can happen is this patient that is in the middle of being transferred to the adult care system and not knowing where to go if there is an emergency. So it should be very, very clear. If there is an emergency, until you see Dr. X in the adult system, you will come to the pediatric hospital, or perhaps in that hospital, they will only see you until you are 17, 11 months and 30 days. So the 31st, or like, they will not see you anymore. So if you turned 18, you have to go to the adult hospital. You need to know what are the rules for you in your geographic region. And you need to know what should you do. So every year, in fact, you should have your doctor updating your emergency seizure protocol, or seizure action plan as it's now being called. So this protocol should answer the following questions to you. What to do if I have a seizure? When should I use rescue medication at home? Or when should someone give me the rescue medication? What rescue medication should I use? How many times can I repeat before calling an ambulance or going to the emergency department? And then finally, when should I call the paramedics or be taken to the emergency room? So all that, it's very important that you talk to your doctor every year and have an updated seizure emergency protocol. I want to talk very quickly about the role of the primary care practitioner. So the primary care practitioner is the only person that will be part of your care throughout this transition period from the pediatric to the adult care. So it's very important that he or she is involved from the beginning. And the PCP can actually help for instance, with referrals to specialists other than your epileptologist. Can make sure that all the referrals are accepted and all aspects of care are in place. The PCP might also be someone that can link you to local agencies that can provide support, both social support and medical support at home. So it's very important to have the primary care practitioner involved from the beginning. And to conclude, adolescents with epilepsy need to have a plan for diagnostic reevaluation, updated treatment plan, and screening of comorbidities. You have to start preparing early, and we say 12 years. The legal, financial, and social support may take up to 2 years to be in place. So again, start early. Get the primary care practitioner on board early. The nurse, the social worker, and epilepsy community agencies should be able to help. So if your doctor is too busy, doesn't have time, ask if there is a nurse that could help you, or a social worker, or go to your, like I said, epilepsy community agency. They can have lots of resources to help with the transition. Very, very important, clarify who is responsible for what. So this doctor will do my referral to my neurologist in the adult side. This other person will be responsible for the referral to my cardiology on the other side, or my neurosurgeon on the other side. So make sure you know who is responsible for what, and try to obtain the best discharge package that you can. You should have a copy of this discharge package as well. Finally, the multidisciplinary clinics with joint visits are the ideal scenario, but if it's not possible, it should not prevent a transition process, a smooth transition process. What can you do? Learn about your epilepsy, learn what are your triggers, what medications you can take, what medications give you side effects, what kind of side effects. Can you tell your medical history? If you are with friends in a place and you have a seizure and they bring you to emergency room and you are getting back to your conscious again, and will you be able to tell your medical history? So that's very important. What medications did you take in the past? What side effects they gave you? What medications you cannot take? All that you should learn. For the parents, after the age of 50 years, I would say encourage your child to speak more to the doctors and nurses. Help them call the pharmacy for refuse. Help them call the doctor's office to complain about side effects. So these things that, like, encouraging autonomy is very important. Of course, you have to supervise that management model that we showed early on. That's what it does. It encourages the patient to take responsibility, initially with a lot of supervision, and as time goes by with less and less supervision. So after the age of 18, this person is able to take care of himself or herself. Again, start talking to your doctor about a plan of transition. Ask which neurologist he or she will refer you to in the adult system. If more than one specialist, ask the question to all of your specialists. Write down their names, addresses, phone numbers. Make sure that the referrals were accepted and you have a consultation date to see them. And ask for an updated seizure emergency protocol. And like I said before, a copy of the epilepsy history form, and finally take charge of your own care. So unfortunately, the beautiful, nice, multidisciplinary clinics are not available everywhere, but you can and should take charge of your own care. Here's just an example of one document, one paper that was we planned. This is for a rare disease called Dravet syndrome, and it is a kind of a transition guide. It's actually a cheat sheet. So a lot of information that can be downloaded in a 2-pager document, and you can have this on your phone. If you need to bring your child to the emergency room, you have that. If it is an emergency room in the adult system and no one ever heard about this disease because it's considered a pediatric disease, at least you have something that you can show the doctors over there. It talks about medication. It talks about particularities of some of the rare drugs that are used for this condition, about vaccines and things like that. So this is for Dravet syndrome, but there are other forms of transition guides for other forms of epilepsy, not too many for the rare epilepsies, unfortunately. Here's some resources that some are for Dravet specifically, but the Child Neurology Foundation, you can find, like I said, the transition of care, and there's a lot of very useful information there. The other one is the ARC Alliance, the last one here on the page, also very useful information about transition. And to finish up this, I would like to invite the participants to answer a questionnaire. This is part of the ILAE, the International League Against Epilepsy. I'm the chair of the ILAE Transition Task Force. And one of our goals was to understand what is the patient's perspective on transition. And we designed a questionnaire that is for patients 12 years and older. So whether you're going through the process, you're 15, 17, 16, or you already went through this process, you're 20 something, it would be important for us to know what is or what was your experience when moving from the pediatric to the adult system. You can scan, we have this in English, Portuguese, Spanish, Romanian, and Chinese. You can scan these QR codes and go to the questionnaire webpage, and I would be very thankful if you could participate in this research. And I will stop here. Lots of people to thank for the development of the guidelines and the more recent work with the ILAE, Paula, Kuratulain, Pooja, and Natalie Chete. So thank you very much. I will stop sharing now. And if there are any questions, I'll be happy to take them. Okay. I see that there's a question here. Cognitive testing, I'm an adult doctor for a while. Can you explain what is helpful for that? So the cognitive testing is very important because as a doctor, you're going to see this patient for a few minutes in your office once or twice a year. It might be very difficult to tell what is the actual cognitive level of this patient. And certainly as an epileptologist or as a neurologist, you don't have the time to go through the testing. So if you can refer your patient to a cognitive testing, then you have an official impression of what the level of cognitive development is for your patient. So that might be very helpful. Okay. Any other questions? I think if there are no other ones, so we'll stop here. Thank you all very much. And I know this will be seen later by patients, so please take the chance to answer the questionnaires. Thank you very much. Bye-bye.